Okay, so let's talk about the gross anatomy of the arm. Good morning, everyone. The arm, also known as the brachium, is the region of the upper limb between the shoulder and the elbow. Functionally, you expect it to connect the shoulder to the forearm, act as a lever for upper limb movement, and houses major neurovascular structures, of course, supplying the forearm and the hand. Anatomically, it is divided into anterior compartment, also known as the flexor compartment, and also posterior compartment, also known as the extensor compartment. Now, compartments are separated by intermuscular septa, of course, which attach to the humerus. Now, for the skeleton of the arm, what is the which skeleton is the skeleton of the arm? That is the humerus, and that's the sole bone of the arm. Uh, you know, uh, 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 um, of course, we've talked about the humerus, but let's go over it again. It has a proximal end, which has a head that articulates with the glenoid cavity of the scapula. It has an anatomical neck. It has a greater and lesser tubercle for muscular attachment. Of course, it has an intertubercular groove, also known as the bicipital groove for the long head of the bicep tendon. It has a shaft. It also has a deltoid tuberosity for the attachment of the deltoid. It has a radial groove for radial nerve and deep brachial, artery. It has a medial and lateral supracondylar ridge at the distal end of at the distal end. You have the trochlear, which articulates with the ulna. We have the capitulum, which articulates with the radius. We have the medial and the lateral epicondyl, okay, for muscular attachment. And of course, we have the coronoid and the radial fossae that accommodates the ulna and the radius during, flexion. And we also have the olecranon fossa, which accommodates the olecranon during extension. And here the clinical relevance is that the fracture of the shaft may actually injure the radial nerve. And when you fracture the supracondylar, it can affect the brachial artery or the median nerve. Now, what about the muscle of the arm, which is the new thing we are going to be talking about? In the anterior compartment of the arm, also known as the flexor compartment, primarily we have it's for flexion of the elbow, okay, and supination. That the bicep brachii is responsible for supination like this. Okay, now what are the muscle? The first muscle is the bicep brachii. The bicep brachii has two heads. It has a long head, that's the supraglenoid, that attaches to the supraglenoid tubercle, and a short head that attaches to the coracoid process, okay, of the scapula. It inserts into the radial tuberosity and of course the bicipital aponeurosis. And it gets its nerve supply from the musculocutaneous nerve, which has a root value of C5 to C6. And of course, the action is that it helps in flexing the elbow and supinates the forearm. Of course, it's a weak shoulder flexion. Okay, it's a weak shoulder flexion. Then we have the brachialis muscle. The brachialis muscle is a deep muscle. It's deep to the biceps. Okay, so it originates from the distal anterior humerus, okay, and of course insert at the coronoid, I think coronoid process and tuberosity of ulna. Now, its innervation is from the musculocutaneous nerve, okay, from the musculocutaneous nerve, and the small, of course, small radial contribution actually, and of course it function to flex the elbow. So we'll say that it's actually the primary flexor of the elbow joint. Then we have another muscle called the coracobrachialis muscle, which originates from the coracoid process and insert to the medial humerus. Of course, also the nerve supply to this muscle is musculocutaneous nerve, and it function to flex and abduct to bring together, to abduct the arm at the shoulder. Then we have, so it is safe to say that the anterior compartment of the arm is actually supplied by the musculocutaneous nerve. Okay, then we have the posterior compartment, also known as the extensor compartment. Majorly, the job is extension of the elbow. It has the tricep brachii muscle, which has three heads: the long head, the lateral head, and the medial head. The long head actually originates from the infraglenoid tubercle of the scapula, while the lateral head originates from the posterior humerus, bit superior to the radial groove. Then the medial head is actually from the posterior humerus, just a little bit inferior to the radial groove. They all insert at the olecranon of the ulna. The nerve supply for this muscle is the radial nerve, which has a root value of C6 to C8. Okay, and the job is for extension of the elbow, and then extension of the elbow and the long head. The long head actually assists the shoulder extension and adduction. Okay, then we also have another muscle called the aconius. The aconius muscle is a very small triangular muscle that originates from the lateral epicondyle of the humerus, of course, insert at the olecranon and upper ulna. Its nerve supply is from the radial nerve, which is at the back of the this place, and of course, its action is to assist tricep in elbow extension. Now, like I said, muscle nerve supply to the anterior compartment of the arm is actually the musculocutaneous nerve. So the musculocutaneous nerve supplies the anterior compartment, while the radial nerve supplies the posterior compartment. So the cause of the radial nerve is that it runs in the medial groove along the humerus, supplies the tricep muscle, and continues to posterior forearm. Here, once you have a humeral, once you have a humeral shaft fracture, it lead to radial nerve injury, and of course there will be wrist drop. For arterial supply, the brachial artery, which is a continuation of the axillary artery, supplies it lies in the medial anterior arm and gives off a profunda brachial artery. Okay, also give give off profunda brachial artery, the deep branch posterior compartment. We also have the superior ulnar collateral artery. We have the inferior collateral artery. We have the for the venous drainage is from the cephalic vein, which is supposed to be lateral, the basilic vein, which is the medial, and tributaries of the joint axillary vein. Here, the brachial artery is palpable at the antecubital fossa, which is a site for blood pressure measurement and arterial cannulation. Now, remember when I said that this anterior compartment and posterior compartment is attached to the humerus through the intermuscular septa. Now, the intermuscular septa is lateral and medial intermuscular septa, that divides the anterior and the posterior compartment of the arm and is attached to the humerus. Like I said, it forms it forms a fascial compartment for muscle and neurovascular structure. Okay, so this is actually very, very important. For surface landmark of the arm, the deltoid tuberosity is actually lateral, the lateral mid humerus. For medial epicondyle is the elbow flexor muscle attachment. We have the lateral epicondyle. Then we also have the bicep brachial tendon, which is actually palpable in the antecubital fossa. Okay, so for clinical correlate, I've mentioned a few about it. But, okay, we can have bicep rupture. When you have Popoe deformity, that's the short head or the long head. We can also have tricep injury, although very, very rare, but usually, as a result of trauma. A lot of humeral fracture can happen from different aspects, which can affect, for example, radial nerve. We can also have brachial artery compression, which definitely lead to ischemia of the forearm, and of course we can have when you have fracture of the humerus, depending on which part of the humerus this happened, if it is at the head, you expect the axillary nerve to be affected. If it is at the distal end, of course, you expect the medial nerve and the lateral cutaneous nerve to be affected. Okay, so the functional summary here is that the arm acts as a lever between the shoulder and the elbow, performing flexion, extension, primarily supination and pronation via the forearm muscle, and of course biceps contribution and transmission of force from shoulder to forearm. Okay, so the neurovascular structures are then protected, but very accessible, making the arm both functional and clinically important. So I hope this helped. Maybe in our next class we'll talk about the forearm proper. All right. Thank you.